Thanks for attending this webinar. Can you hear me okay, Melba?
Yes.
Okay, very good. I'm trying to get fancy and trying out this new headset. So I had some reports in previous webinars that some kind of things were distorted with my voice, and hopefully this will help. So we've got a pretty broad topic to discuss tonight: cervical spine disorders. This is probably a full day lecture if I was teaching to medical students, but we're just going to try to talk about some common things, and then maybe review some not so common things and answer any questions you might have. Let's see. Are you seeing my screen right now, Melba? No.
Yes, I can see your screen. Yes.
There we go. Okay. So just a little bit about my background. I was trained as a neurosurgeon. I trained at the University of Utah in Salt Lake City. After my residency, I spent some time in Germany working with a trauma surgeon, which is basically in Europe in those days was kind of a combination between an orthopedic surgeon who specialized in trauma and a general surgeon that specialized in trauma. And that was a great experience. From there, I spent a year at Rothman Orthopedics in Thomas Jefferson University in Philadelphia doing a combined fellowship with neurosurgery and orthopedic surgery. That was a great experience. From there, I went on to the University of Illinois College of Medicine, Peoria, in central Illinois, where I practiced for 16 years and was involved in neurosurgical training, both of residents and fellows. And then I joined Rothman Orthopedics at Advent Health in 2022 here in Orlando, Florida. So in terms of what I do, I evaluate and treat patients with spinal conditions, evaluate whether surgery is a good option for treatment, and most patients are evaluated and treated initially by other physicians prior to getting a surgical opinion with me. In most situations, surgery is not the first option for most patients. So usually we want patients to try some conservative treatments, whether that might be physical therapy, in medications, injections. There are some conditions. So if a patient's having weakness, we kind of skip past some of those treatments, and patients ultimately end up seeing a surgeon right up front. In terms of what conditions I treat the entire spine from the head down to the coccyx. So down from the neck down to the lower back. We treat radiculopathy, which are pinched nerves, typically in the cervical spine, which we'll discuss tonight, as well as in the lumbar spine. Myelopathy, that is damage of the spinal cord, and we see that in the cervical spine. We do not see that in the lumbar spine because the spinal cord actually ends before the lumbar spine. Scoliosis, these are deformities, so I do a lot of spinal deformity in my practice. I have a big interest in spinal oncology and tumors. And then, of course, I get to see a lot of patients with low back pain and neck pain. So in terms of our spinal anatomy, we have three main sections of the spine. We have the cervical spine, the thoracic spine, and the lumbar spine. This is where most of our flexibility is. Most of our flexibility is actually within the cervical region and the lumbar region. Within the thoracic region with the rib cage, there's less flexibility. And then within the spine is the spinal cord and the spinal nerves. So between each of the vertebrae, there are nerves which leave the spine, and those nerves supply various things. So in the cervical region, the nerves leave the spine and supply the arms in terms of sensation, as well as supplying the muscles to control movement. In the lower back, similar, we'll have in the lumbar spine, those nerves going into what's called the plexus to supply the legs to control the legs. So in terms of the spine itself, each segment of the spine is what we call an intervertebral motion segment, and it's comprised of the adjacent vertebrae with a disc between the two vertebrae, which is a shock absorber, which you can see here. Hopefully you can see my pointer. And then the facet joints in the back. So the facet joints are joints in the back to help control movement. So it's the way the facets are designed in different areas of the spine. It allows for different types of movement. And here is what we call a foramen between the two vertebrae where the nerves will leave. So in terms of the function of the spinal canal, this function is to allow for movement and support weight of our body so that we can stand erect and walk, as well as protect the nervous tissues, that being the spinal cord, which is passing down through the canal of the vertebrae, and protect the nerves that are leaving between each of the vertebrae, what we call a intervertebral foramen. The intervertebral disc, this is a very unique structure in that it's composed of kind of a soft gelatinous material inside that helps absorb shock and kind of diffuse forces. And then the outer part of the disc is designed like a radial tire. So there's fibers that are oriented in different directions over multiple layers that allow us to twist or torque our spine, that give us some of the great flexibility that we have. So people often ask, do I have degenerative disc disease? And for most of us, the answer is yes. Almost all of us are going to develop some degeneration within disc throughout the aging process. In a lot of us, this is actually occurring in our teenage years. You know, by age 30, we're seeing probably 20–30% of people with degenerative disc in their lumbar spine or their cervical spine. So how does this happen? So what happens is the disc is unique in that there's no blood supply to the disc. So there's a few cells within this disc that produce proteins. And since there's no blood supply, those cells are very sensitive. And in certain patients, certain families, there's a prevalence of the cells within the disc dying. And when they do, they quit producing those proteins. The inner part of the disc gradually dries out. When it dries out, it collapses. And then when it starts to collapse, it changes the biomechanics such that it allows for more micromotion and in turn more degeneration. So what by far the biggest factor in terms of disc degeneration is genetics. So if you are in a family where you've had mom and dad and have had spinal issues, you have a high likelihood of having spinal issues as you age. And if we look at examining normal subjects with MRI, as I mentioned earlier, depending on age, you're going to see a lot of patients that have degeneration within her spine, whether degenerative disc, bulging of the disc, herniation of the disc, and stenosis. And these are patients without symptoms. So everyone is going to have some degeneration within their spine, and that is kind of normal to see. Obviously, in some patients, it can produce symptoms, and that's a little bit more worrisome, and that's why we're here tonight. So in the cervical spine is comprised of 7 vertebrae. So the skull sits here on top of the first vertebrae. This is actually the second vertebrae. The first vertebrae is removed in this particular diagram. So this would be cervical 2 on down to cervical 7. So we have a lordotic posture, which is kind of an angle back. There are facet joints in the back, and they're kind of angled to prevent translation of the vertebrae forward. We have discs between each vertebrae that absorb shock. Here is a cadaveric cross-section. So here we have our base of our skull. Here we have the base of our brain, and this is our spinal cord. So this would be the second cervical vertebrae, which is a peg that sits up. The first cervical vertebrae is a ring. So the sides of the skull rest on the sides of that ring of the first cervical vertebrae. We have there the second cervical vertebrae, and then we call the subaxial spine, and the spinal cord is going down through a canal centrally. So here again is the spinal cord. So here's the base of the skull, and we remove the back of the spinal canal in this particular cadaver. We're looking at the spinal cord, and then we're looking at the nerve roots leaving between each of the vertebrae. So here's a diagram or some images of the base of the skull. So this is the inside of the skull where the back of the brain sits, what we call the cerebellum. This is the foramen magnum, where the spinal cord starts heading down through the spinal canal. And then on the base of the skull is what we call occipital condyles, which form a joint with the first cervical vertebrae. The first cervical vertebrae is unique in its design. So it has the skull, which sits on top of what we call lateral mass off on the side. And then there's a peg from the second vertebrae, which sits up inside of this ring. and it allows us to turn our head side to side. So there's a lot more flexibility within the joints of the first and second vertebrae than we see in other areas of the cervical spine, and definitely other areas of the lower spine, the thoracic spine, and the lumbar spine. So the second cervical vertebrae, as I mentioned, has a peg. So here's the peg. We call that the odontoid. And then around that is the ring of cervical 1 that allows for a rotation there between the first and second vertebrae. Between these two vertebrae, between the occiput and cervical 2, the ligaments are a little different than the other are in other locations in the spine. And this is to facilitate that extra movement or flexibility in these regions. These ligaments allow for more movement, but yet they're very strong. So the ligaments in this area are thickened, and then there's extra ligaments in comparison to other areas of the spine. And then in what we call the subaxial spine, most areas in the spine, the thoracic spine and lumbar spine, we think of 3 joints. We have a disc and we have 2 facet joints in the back that make up 3 joints. Well, in the cervical spine, the vertebrae, what we call the vertebral bodies, are kind of cup shaped. So one sits down in the other, and we call these uncovertebral joints. So this cup forms a 4th and a 5th joint essentially in the cervical spine, which is kind of unique. Between the vertebrae, between those uncovertebral joints, this is the neural foramen where the nerves are leaving. This is a common location where we'll see arthritis form, bone spurs form that can pinch nerves and produce symptoms in patients. So what type of problems can we develop in our cervical spine? So as I mentioned, most everyone is going to develop some form of spinal arthritis in their lifetime. Obviously, some of us are going to form a lot more arthritis than others. Pretty common to have neck pain related to arthritis. You can also have neck pain related to muscle strains. Radiculopathy, so this is a disorder where there's pinched nerves and the nerves leaving the spine, and this can be produced by either bone spurs forming from arthritis or disc herniation. So a portion of the disc can either bulge out or leak out, what we call herniate, and can irritate the nerve as the nerve is trying to leave the spine. And then the other condition we have is myelopathy. So myelopathy is a disorder of the spinal cord or damage to the spinal cord and is associated with spinal stenosis. Spinal stenosis is a radiographic term that means narrowing of the spinal canal. So cervical radiculopathy, as I mentioned, this is a disorder of the nerve root. So as the nerve is leaving, that nerve root gets irritated from some sort of pathology, whether it be a bone spur or a disc herniation. Cervical radiculopathy is a diagnosis that's made clinically. By clinically, we mean what the patient is describing in terms of symptoms. So we don't just talk about cervical radiculopathy based on x-rays, based on MRIs. Those x-rays and MRIs can help us determine where radiculopathy is coming from, but the diagnosis is made by the clinical pattern of symptoms that a patient is describing. So typically with a cervical radiculopathy, most patients will have neck pain, often unilateral, so on one side. That pain oftentimes travels down into the scapula or shoulder blade. Pretty common. Most patients with a cervical radiculopathy will have pain in the scapula. Many of them will have pain that also radiates down the arm in the distribution of the nerve that is irritated. And I'm going to show you a diagram in a second. These nerves in most people follow a typical pattern where certain nerves go to certain areas of the arm. So based on the description of pain and numbness, we can figure out which nerve we believe is irritated, and then that helps us look back at the MRI and see if we see corresponding nerve compression. Many patients will have difficulty sleeping with cervical radiculopathy. I've experienced this myself, and it's definitely dependent on your position. Certain, laying on one side might cause nerve irritation because your head is tilted, closing off the nerve tunnel. And then sleeping on the other side could help open up that nerve tunnel and help with your symptoms. So a lot of patients have difficulty sleeping, have to change their sleeping patterns with a cervical radiculopathy. Most patients will not have weakness, but weakness is possible. I would say weakness is probably present in about 10% of patients with a cervical radiculopathy. And in most patients with a cervical radiculopathy, they do not like to look up. So when you look up, you are narrowing the nerve tunnels. So if you have an irritated nerve and you narrow the nerve tunnel by looking up, it's going to produce more symptoms. So most patients with a cervical radiculopathy do not like to look up. They kind of have their head tilted forward a little bit, which creates a little bit more room for the nerve. Oftentimes tilt their head to the asymptomatic side. That also opens up the space for the nerve. So in terms of our nerve roots, so we have a number of nerve roots that leave in the cervical spine. We have 8 cervical nerve roots that leave between the vertebrae. And of these nerve roots, the cervical 5 nerve roots down to the cervical 8 nerve roots go into the arm. And most commonly, we're seeing patients that develop symptoms with pain that radiates into the arm. You can have a radiculopathy or an irritated nerve up higher that does not produce pain or symptoms into the arm, but this is much more complex to figure out. This is oftentimes a unilateral or single side neck pain, and it can be very challenging to treat. And then we have a lot of issues with insurance carriers in terms of getting approval or authorization to treat pinched nerves in this area because it's less common. So in terms of how common is radiculopathy, so most patients in most adults are going to experience neck pain and arm pain at some point in their life. Greater than 50% of us are going to have developed these symptoms at some point. Fortunately, about 3/4 of us, these symptoms are going to respond to non-surgical treatments. So here I was mentioning the distribution of various nerves. So this is what we call a dermatomal map. So the various nerve roots. So the yellow is the cervical 5 nerve root, which provides sensation over the shoulder. Cervical 6 nerve root, which exits between the C5 and C6 vertebrae, supplies sensation down to the thumb. The C7 nerve root oftentimes comes down to the index finger and middle finger, and then the C8 nerve root out to the ring finger and little finger of the hand. As I mentioned, the upper cervical radiculopathies, those can also produce symptoms, typically not into the arm. These are more challenging to diagnose and more challenging to get insurance authorization for. The insurance companies do not like us treating patients because there's many sources for neck pain, but there are occasions where you can have a pinched nerve in the upper cervical region that might produce neck pain alone. And there are times where if you have not improved with non-surgical treatments, surgery might be a consideration, but we'll definitely have greater struggles trying to convince the insurance carriers that surgery is a reasonable consideration. So on MRI scans, so there's a high predominance of disc degeneration and narrowing, even in asymptomatic people. So if you're in a motor vehicle accident and you have a little bit of neck pain and they jump off and get an MRI scan early, you might find that you have a pinched nerve. But many patients, even though there's narrowing and pinching of that nerve on the MRI images, a lot of patients are not symptomatic. So the key thing is having symptoms that corresponds with the area of compression. If you're not having symptoms, we're usually not going to treat. So in terms of if you do have symptoms, radiating pain into arms, how do we treat? Most patients are going to start out with some non-operative treatments. Most situations, that's going to involve physical therapy and anti-inflammatory medications. Anti-inflammatory medication meaning non-steroidal anti-inflammatory medications, possible steroid medications. In many situations, we do not get an MRI scan early on because one, the insurance carriers don't allow us to get that until physical therapy is completed. So they know that many patients are going to respond to non-operative treatment, and there's no need for expensive advanced imaging if it's not going to guide treatment. So we usually start out with non-operative treatments. If these symptoms are still present 4, 6, 8 weeks after trying non-operative treatments, that's when we'll consider an MRI scan and maybe consider other treatments such as epidural injections, which is a steroid that's injected around the inflamed nerve, a small procedure. And if those things fail, then sometimes we're considering surgery. In terms of our surgical indications, is persistent, uh, typically arm pain or radicular symptoms that haven't responded to non-operative treatments. Patients with neurological deficits. So as I mentioned, about 10% of patients might develop issues with weakness in the scenario of a radiculopathy. And in those patients, we will skip the conservative treatments and try to get that nerve decompressed as early as possible to improve the likelihood that the patient gets their strength back. Instability. So if we have a situation where a patient has abnormal movement, say arthritis has destroyed joints or the disc to the point where there's slippage of the vertebrae that's jeopardizing the neurological elements, sometimes we might consider surgery for that. And the big thing is we want our clinical symptoms, the pattern of pain that a patient describes, to correlate with our radiological findings. So we want to see a nerve that's pinched on the MRI, and does that correspond with the patient's symptoms? If those two things come together, that gives us the highest likelihood that we're going to help that patient with any surgery. In terms of our surgical options for radiculopathy, our options range from anterior cervical discectomy and fusion, which is a very common procedure. It's been performed for about 80 years. We have seen some improvements. I would say we've not seen dramatic improvements probably within the last 20 years. Historically, 20 years ago, we would harvest bone from the hip. I would say we no longer harvest the patient's own bone because that's oftentimes more painful than the surgery itself. And we've come up with implants that help with the fusion and healing, that we no longer need to harvest the patient's own bone. We can use either substitute like cages, or we could use donor bone or cadaveric bone without harvesting the patient's bone, with good success rate for fusion. Cervical discectomy and arthroplasty. So this is a where we're doing a decompression discectomy. And then arthroplasty means putting in an artificial disc that maintains flexibility. Where with the anterior cervical discectomy and fusion, we are sacrificing flexibility. And then posterior laminar foraminotomy. This is a technique where we come in through the back of the spine and create a small window around the nerve to try to create some room for the nerve to settle down compression and inflammation. So in terms of the anterior cervical discectomy and fusion, the advantages are by coming in through the front, it's actually a very easy surgery for patients. The spine is about 1 inch beneath the skin in most patients of normal body habitus. So it's pretty easy for us to get to. We don't have to cut through any muscles to get to. There's simple tissues that spread apart that give us access. And then the bone spurs or the disc herniation is sitting in front of the spinal cord and in front of the nerves. So it gives us a direct access to remove that pathology that's irritating the nerve or irritating the spinal cord. So we oftentimes prefer to do anterior approaches to the spine because our patients do better. They have less pain than posterior approaches because we're not cutting through muscles. And we also have great access to get the nerves decompressed. So we favor anterior approaches. The main issue with a fusion, the disadvantage of a fusion, is the potential for adjacent segment disease. What this means is when we sacrifice movement with a fusion, the other joints in the spine have to work a little bit harder, and then they can develop arthritis and have problems as a result. Studies have shown that about 18% of people 10 years after surgery will have another surgery to address adjacent segment disease. This is a picture of the fusion. So here we're seeing a plate on the front of the spine. We've removed the disc. We've put in bone grafts here. So that's what an anterior cervical discectomy and fusion would look like. And the goal of this surgery is to get these 3 vertebrae that were adjacent to these 2 discs. So we eliminated 2 discs or 2 joints, and these vertebrae are all going to join together. Okay, so you're going to lose a little bit of flexibility, but then in turn, the joints above and below have to work a little bit harder and have the propensity of developing arthritis. Posterior approach, the issues with the posterior approach, it can be a small, delicate surgery. It can work for some patients. But the biggest issue with a posterior surgery is oftentimes our pathology. The bone spur or the disc herniation sits in front of the nerve root. So that can make it challenging to get these areas decompressed. Cervical arthroplasty. So this is a technique where we remove the disc, we free up the nerve to relieve the nerve pressure to take care of the patient's inflammation and symptoms, but we still preserve motion by having this device that allows for similar motion as the native, the human disc. So this has advantages in theory in that it reduces stresses on adjacent segments and might not cause as much arthritis at adjacent segments. The disadvantages are with the cervical disc, we cannot be as aggressive with our decompressions. So if we have a patient with a large bone spur that's growing into the nerve tunnel, it can be very challenging to remove that bone spur. Oftentimes we have to remove a part of that cup-shaped joint that we call the uncinate process, and in turn we destabilize the spine. So if we destabilize the spine and put in a device that maintains movement, this can result in more arthritis and problems. So probably the best indication for surgery, for disc replacement surgery, is what we call a soft disc herniation, where a small piece of the inner disc leaks out. I would say I do not use it as frequently for hard disc or osteophytes. So osteophytes, bone growth coming out of the joint that irritates the nerve. So our goals with these surgeries is kind of a balancing act. We want to get the nerves decompressed. We want to preserve as much flexibility in the spine and integrity of the spine as possible while minimizing the operative risk and morbidity for patients. So every case is individualized. You know, we have to look and see how much arthritis is at adjacent segments and try to make good decisions for patients that's going to limit the risk for further surgeries and issues as they age. So here's a case example. This is a 46-year-old female. She developed neck pain and radiation of pain into her right shoulder. Her symptoms started suddenly one morning, and that's pretty common scenario. Very few patients, I would probably say 5% of patients that I see describe a scenario where they had an injury or something, they were playing sports and something happened acutely. Most patients simply wake up and suddenly the neck pain, the scapular pain, and arm pain is there. Over the last week before she came to our office, she's had some weakness, so she can't lift her arm above her head on that same side as the pain. So she has some weakness. So we're going to treat this patient a little different than other patients. She also has numbness and tingling over the left shoulder. So her symptoms seem to correspond very well with a cervical radiculopathy, irritated nerve. Here we are thinking it's probably going to be the C5 nerve based on the distribution, pain in her shoulder, weakness in the deltoid. Both of those things are supplied by the C5 nerve root. So after being seen, she had an MRI scan ordered urgently. So we order this study stat because we want to find out what the source is for this patient's weakness. And if there is compression on that nerve, we want to get this patient to the operating room and get that nerve decompressed. So this is the scenario where we have to fight and argue with the insurance carriers about the need of why this patient needs an MRI scan, where other patients might be able to wait to complete physical therapy and have their MRI scan ordered after therapy. So this particular patient oftentimes requires more phone calls and more negotiation with the insurance carriers and better documentation on our part as physicians. So we get her MRI scan, and this is her MRI. So here we're seeing the base of her skull. This is the base of her brain. Here's the spinal canal. We're off a little bit to the right side. These are the discs, the shock absorbers, and here is the issue. So this disc between the 4 and 5 has herniated. And then here is a cross section. So on a cross section, the left side of the picture is actually the right side of the patient's body. And here's a disc herniation here that's irritating the C5 nerve as it's trying to leave. So for this particular patient, we take her urgently to the operating room. By urgent, I mean within the next few days, next week. We do still try to get insurance authorization through the insurance carrier, but that can be a challenge nowadays because sometimes insurance carriers require 4 weeks. But like I said, there's ways around things. We have to talk to them in person, and try to get this patient taken care of in a timely fashion. So in this particular case, we came in through the front of her neck, did a discectomy where we removed that entire disc, removed the fragment of disc that was around that C5 nerve root, and then we put in a artificial disc. So here we're seeing titanium plates, which will have a porous surface, and the bone grows into those plates. Inside between those two devices is a plastic core that you can't see on the x-rays, and that core moves and allows for movement. So here we're preserving flexibility between these two vertebrae. So when she leans back, we can see the back of those vertebrae come together. And when she tilts her head forward, we see that those two vertebrae open up. So there's still adequate motion between those vertebrae. And in theory, that's going to reduce her risk for adjacent segment degeneration as she ages. So moving on to cervical myelopathy. As I mentioned earlier, cervical myelopathy is a disorder of the spinal cord. So it's a spinal cord disease. So here's an MRI scan. Here we're looking at the spinal cord. The white is spinal fluid, a cushion. And here we can see we have a large bone spur pinching the spinal cord. And normally the spinal cord is gray. Here we see a little white within the spinal cord, which is bruising or damage occurring within the spinal cord. And the spinal cord is that the longer this is present, the longer this compression is there, the more at risk the spinal cord is for further damage. And the term we use is stenosis. Stenosis means a narrowing of the spinal canal. So normally the spinal canal has a diameter of about 17 to 18 millimeters between C3 and C7. Patients with symptomatic stenosis, oftentimes the spinal canal is down to 10 millimeters or less, causing significant compression upon that spinal cord. So these patients oftentimes have very little pain. These patients present with, they typically describe weakness, but in most situations, it's not actually weakness. In most situations, it's actually coordination issues. So they have trouble with coordination and dexterity in their hands, in their legs. They have a lot of trouble with balance and walking. I'll ask them, are you walking like you're drunk? Oftentimes the answer is yes. They have what we call spasticity. Their reflexes get abnormally strong, and they have uncontrolled movements at times in their upper and lower extremities as a result. Advanced cases can have bowel or bladder dysfunction, and some patients can have true weakness where they've lost strength in particular muscle groups. Indications. So in most situations, non-operative treatments result in progression over time. So that spinal cord is still compressed, no matter how we treat that. Physical therapy, immobilization, most patients are going to progress with time. So in most situations, we think that operative, getting the pressure off the spinal cord improves the likelihood for halting of progression. And we actually, more modern studies have shown that about 80% of patients will see improvement after we get the spinal cord decompressed surgically. So the consensus among most spine surgeons is that patients with symptoms of myelopathy and MRI scans showing cord compression, in most situations, we would recommend surgery for the vast majority of those patients. Now, if it's an 85-year-old patient and they have severe heart disease and they can't tolerate surgery, that might be a different story. We're more apt to maybe follow those patients for a little bit longer. So factor fission, I hear a lot of these quotes with patients that have seen other surgeons. With a neck as bad as yours, you could be paralyzed if you fall or get into a minor car accident. And yes, this is true. It is possible that you could be paralyzed with a fall or a minor car accident. But the studies have shown that we probably don't benefit patients by doing a prophylactic surgery to prevent paralysis. So I would say that this is oftentimes overstated by a lot of surgeons. If a patient is not having symptoms of myelopathy and we see spinal stenosis, in most situations, I am not going to recommend any treatment because there's risk of surgery There's risk of more surgeries down the road and more problems down the road. And I strongly feel that unless the patient's having symptoms, we do not operate. If you don't have surgery, you will progressively get worse and the damage in your spinal cord may be permanent. Well, that can be true. So if you are having symptoms of myelopathy, so if you're already having issues with strength and coordination, and their spinal cord compression, um, things are likely going to get worse with time. And the longer it goes, the more likely that those issues are going to be permanent. Surgery will prevent you from getting worse, but might not make you better. That is true. So surgery is often described as preventative. When I was in training 20 years ago, we would describe this as a preventative surgery. But with modern surgical techniques, and we have done a number of studies that show that about 80% of patients will see improvement in strength and coordination after we get the spinal cord decompressed. Sorry, I just froze up. There we go. So just a couple case examples. This is a 74-year-old male. He's having progressive numbness, coordination problems in his arms, his hands, difficulty walking. He's noted changes for about the last 6 months, more rapid in the last 3 weeks. So he's having more and more issues with his walking, his gait. And he started having more significant neck pain about 3 months ago. Here are his x-rays. So on his x-rays, he has pretty significant spinal degeneration. I can see that many of these discs are collapsed. There's also slippage of the vertebrae, so I can see a slippage here between cervical 4 and cervical 5. Okay. So these are plain x-rays. We don't treat off of the plain x-rays, but when we see this patient with neurological deficits, we're going to order an MRI scan. This is not going to be a patient that we send for physical therapy. So here's his MRI. Here's the base of the brain. This is the spinal cord. The white stuff is spinal fluid, which is a cushion for the spinal cord. And we can see that the spinal cord is pinched here in multiple areas from the arthritis. So the disc degenerates, it bulges, the ligaments in the back thicken, and those two things together pinch the spinal cord and can damage the spinal cord. And these are cross sections. So here between 6 and 7 is kind of a normal cross section. We can see the spinal cord, we can see spinal fluid around it. At the other areas, we don't see spinal fluid. We can see that the spinal cord is pinched between bone spurs or disc bulging in the front and thickening of the ligaments in the back. So there's a number of different approaches that could be considered to treat this patient. Some surgeons would prefer to do an anterior approach. So in this particular scenario, where they come in and remove all of these discs, shave off the bone spurs, remove any discs that are pinching, and place a plate on the front of the spine. For a multi-level surgery like this could carry risk for swallowing problems and a hoarse voice. For those reasons, if I'm doing multiple levels, I would prefer to do the surgery posteriorly. So posteriorly, we do what's called a laminectomy, where we remove the back of the spinal canal. So we've removed the back of the spinal canal here, and then we lock those vertebrae together because we have weakened the spinal canal by removing the back of it. So we do a fusion where we lock it together with screws and rods and try to get these vertebrae to grow together or fuse together. So you can see how this patient's spinal cord looks now, much improved. We can see spinal fluid on both sides of the spinal cord. It's another case. This is a 49-year-old female who's had similar issues. She's losing function. She does have pain between her shoulder blades. She has numbness in her hands, coordination problems in her arms and the legs. Big factor with this patient is she's overweight. So treating a patient that's overweight can be very challenging. But so if she had neck pain, if she had a pinched nerve type pain, we'd probably say no to surgery. But here, this patient has spinal cord compression and she's losing function and she has risk for permanent deficits in her spinal cord. So higher surgical risk, but she still needs to have it done. We need to find a way to get her spinal cord decompressed. Her particular case, we came in through the front of her neck, took out this disc between 5 and 6, 6 and 7, shaved off bone spurs under a microscope, and did an anterior cervical fusion. That's going to be an easier surgery for this patient to recover from. Then coming in through her back here, we can see her fatty tissues in the back. By opening up there, she's going to have more pain and a greater risk for an infection because these fatty tissues have a very poor blood supply. But we're able to get this patient's spinal cord decompressed, halt her neurological decline, and allow her to get into therapy and relearn how to walk and ambulate and give her some quality of life back. Rheumatoid arthritis. So rheumatoid arthritis affects about 1% of our population. This is an autoimmune type of arthritis. And with this type of arthritis, there is a predominance of involvement in the cervical spine. So with rheumatoid arthritis, you have inflammatory mediators that go into the joints, and that destroys the cartilage, destroys the ligaments, and ultimately can destroy the bone in multiple joints within the body. And the cervical spine is a very common location to see the ramifications of rheumatoid arthritis. When I was in training 20 years ago, we used to see patients. I used to operate on patients probably once or twice a week. Now, with more modern medications, it's becoming much less prevalent. We're able to control this disease much better. So what we see with rheumatoid arthritis in the cervical spine is, as I mentioned earlier, the upper portion of the spine has a lot of flexibility and a lot of complex ligaments. Well, with rheumatoid arthritis, those ligamentous structures get destroyed and it can result in instability. And the three common things we see are atlantal axial subluxation. What that means is the first vertebrae dislocates on the second vertebrae and can pinch the spinal cord. Atlantal axial impaction is where that peg of the second vertebrae gets driven up into the base of the skull and again can pinch the spinal cord. And subaxial subluxation means that the joints are getting destroyed in the lower cervical region and allowing for slippage of the vertebrae or abnormal movement. So here's an example of atlantal axial subluxation. So this patient, the first ring has slipped forward, dislocated forward. Arthritis has formed a big pannus, tissue, thickening of tissue, and it pinches the spinal cord and damages the spinal cord, producing symptoms of myelopathy. And as I mentioned earlier, this is due to destruction of those ligaments that are unique between cervical 1 and cervical 2. So again, here's a picture, a close-up of that pannus inflammatory tissue. From those inflammatory mediators that's destroying the ligaments. And this is the ring of the first vertebrae. It slips forward. And again, this is the back of the first vertebrae, and it can pinch the spinal cord as a result, producing myelopathy. Atlantal axial impaction. This is where the odontoid process is driven up into the base of the skull or the foramen magnum. And here's a depiction of that. So this would be normal. The second vertebrae, that peg, sits below that foramen magnum. With time, as these joints get destroyed, everything collapses, and that peg progresses up through the base of the skull and can pinch the spinal cord. So here's a MRI depicting that. So here, this is that peg. We can see how it's pushing up on this patient's brainstem and spinal cord. These patients oftentimes can have myelopathy. They can also have issues there are nerves that come off the lower aspect of the base of our brain that go to our esophagus, our larynx, and help with swallowing function. So these patients can have issues with swallowing. They can have a hoarse voice. A lot of what we call cranial nerve issues can also occur with basilar invagination or settling. And then the subaxial subluxation. So here we can see the vertebrae are slipping forward abnormally. And this can result in pinched nerves or radiculopathy, or as well as pinched spinal cord and myelopathy. The good news is with rheumatoid arthritis is our medications are so much better than they were 20 years ago. And I've gone from operating on one patient a week to probably one or two patients a year. So we've seen dramatic improvements, much less spinal degeneration in the cervical spine with our newer rheumatoid medications. Deformities of the spine. So I do a lot of deformity surgery. The most common deformity we see in the cervical spine is kyphosis or chin on chest deformity. And most of these deformities are caused by surgeries. Prior surgeries weaken the spine. A lot of times it might be poor techniques are used that weaken the spine, particularly the back of the spine, weaken the muscles, and allow the spine to gradually fall forward into what we call kyphosis. In some of these patients, their chin will rest upon their chest and they cannot lift their head up off of the chest. Got a couple cases that show this. So this is a 53-year-old female. She's had prior surgery where the surgeon did what's called a laminectomy, removed the back of the spinal canal. They thought that they saw a tumor. And looking back at the case, I don't think that there was any tumor there. I think this patient just had a little bit of arthritis, a little bit of a bone spur. And then they put screws and rods in. Um, their pathology came back as benign, so there was no cancer there. And then they came back for some reason, the patient fell into kyphosis, and they decided to remove the screws and rods from the upper part of the spine. It wasn't healed yet or fused together, and then they fused the patient in a kyphotic position. So this is kind of a recipe for disaster. Um, the patient's had progressive deformity. She cannot hold her head up off of her chest, and then she's also had some issues with weakness and coordination. So this is that poor patient. She is trying right now to lift her head up, and you can see her chin is resting on her chest. Here we can see the bones. These are the bones, what we call the spinous processes. And because she's leaning forward, it stretches her skin out, and those bones protrude to the skin and make them much more prominent. Here are some x-rays. So the spine should have a contour, should have a contour back up here. So her head should be sitting up here. Instead, her head is leaning forward. And this is with her maximally trying to lift. So she can lift her chin, about an inch up off her chest, and that is it. And then here's her MRI. So in addition to having the kyphotic deformity, she has spinal cord compression here. So this is a very complex case to go back and try to fix. So what we did is we removed the existing screws to loosen things up. We decompressed her spinal cord. And then we did what's called osteotomies, which are basically remove bone and create fractures in the spine. That's going to provide a little bit of flexibility. We put her in traction to recreate alignment in the spine. And then we come back in and we do fusions both through the front of her neck as well as through the back of her neck. So here are her x-rays. This is after her fusions. So here we have placed grafts between each of the vertebrae to distract those vertebrae apart and restore her normal alignment. We have a plate on the front of her spine and screws in the back of rods in the back of her spine to hold her in that alignment. So this is before surgery. We can see how she's leaning forward. This is after surgery. So she has what we call a normal lordosis. Her head now is sitting above her spine, which would be down symmetric above her pelvic bones. And this is how she looks after surgery. Before, her chin was resting on her chest. Now we have her looking straight ahead, and we dramatically improve this patient's quality of life. Second case is similar. This patient's had 2 spine surgeries for a condition that we call Chiari malformation, which is a disorder at the base of the skull where there's extra tissue that protrudes down through the base of the skull and blocks the passage of spinal fluid, which can result in spinal fluid depositing inside of the spinal cord called a syrinx. The surgeon that did this did a initial surgery where they moved the back of the skull to open up this space to allow spinal fluid through. In addition to that, the surgeon, for some reason, also did a laminectomy down here, which weakens the spine, and they also opened up into the spinal cord. I don't think that was probably needed at the first surgery. I would probably just done this first step of the surgery, what we call a posterior fossa decompression. But anyway, they weakened the back of the spine. So she has this procedure. She has some short-term improvement. She returns with persisting headaches. She has pain in her arms, likely due to them creating some damage in her spinal cord by opening up the spinal cord. Anytime you go inside of the spinal cord, you're going to damage it. This is a follow-up MRI scan about a year after her first surgery. So she no longer has the fluid within her spinal cord. We can see where they've weakened her spine here. We can see this area where they've done an adequate decompression, allows spinal fluid to pass through this area. But for whatever reason, the surgeon decided that the patient needed to have a second surgery. So they went in and they did more work up here, weakened the muscles to a greater extent. Now this is a year after that. Now you can see how her spine is gradually falling forward. And this is how it is a couple years later. So again, she has a chin on chest deformity. She's having significant difficulty looking upright. So this is what we call a scoliosis x-ray, where we can see the entire spine. And you can see this patient's line of sight. So most of us want to look straight forward. This patient is looking down at the floor all the time. So this creates a lot of issues with cosmesis. So this patient doesn't want to be seen in public. She's embarrassed about her appearance. And it also creates functional problems. She can't see, 10 feet ahead when there's a curb coming or something that she's going to trip on. So major issues. And a lot of these patients also have significant pain. So this patient underwent a similar procedure. We came in and we did what's called osteotomies. Some of her joints had grown together, so we removed the bone between those joints to provide some flexibility. And then we did a surgery through the front of her neck and a third portion of the surgery through the back of her neck. So here we've removed the joints to give some flexibility. Right now we're coming in through the front. We're going to take each of these discs out, distract them apart, which is going to give us some of that normal curvature back, put grafts of bone in where the discs were, and put a plate and screws similar to that last patient. So we can see how we've improved this patient's alignment and ability to look forward. So again, here is before surgery, here is after surgery. And this was about 1 month after her surgery at her office visit. And it was the first time in 2 years that she agreed to have her picture taken. She was thrilled with the results and her ability to look forward. Cervical trauma, so traumatic injuries are pretty common in cervical spine. There is potential for paralysis due to the presence of the spinal cord. This could be an hour discussion. I'll just show one brief case. 39-year-old male intoxicated on an ATV, and he drives his ATV into a irrigation hose, which is suspended. So he basically clotheslines himself, complains of severe neck pain, and he's very fortunate. So he has dislocated the base of his skull from his spine. So there's ligaments that hold the base of the skull onto the first vertebrae. We can tell that there's been separation there. So this gap is abnormally large. So he has essentially been decapitated but survived. So occasionally you'll see a story like this online where a surgeon reattaches the patient's head. This is the type of case that we're talking about. Most patients don't survive this injury. Most patients will die. Dale Earnhardt, so this is the injury that Dale Earnhardt had in his NASCAR crash. He dislocated the base of the skull from his spine and died as a result, but there are a small percentage of the patients that will survive. This is an emergency, so we take this patient to the operating room and basically reattach his head. So we put some plates and screws into his skull, put some screws into the first and second vertebrae with some rods that holds it back together, and reattach things, stabilize things, and he can have a full recovery and amazingly have no neurological deficits with this type of problem. Cervical tumors, so tumors can involve the bone, the spinal cord, or the spinal canal. We most commonly see it involving the bone. Most commonly, this is going to be a metastatic tumor. So you might have a breast cancer or a lung cancer that spreads to bone. That might involve the cervical spine. It can destroy the bone and in turn put pressure on the spinal cord or nerves and produce symptoms. So this case is an 84-year-old female. She's had progressive decline consistent with myelopathy. So she has numbness in her arms and her legs. She's having a lot more trouble with her balance and walking. Most 84-year-old people are like, well, I'm just getting older. That's part of getting older. But eventually she sees a physician and we get appropriate studies. She has a pacemaker, so she cannot get an MRI, but we're able to get a CAT scan. So this is her CAT scan. Here we're seeing the base of her skull, first and second vertebrae. So normally we have a spinal canal with nothing in the spinal canal. The spinal canal is soft tissues, which do not show up well on a CAT scan. In her spinal canal, we have a large calcified mass that you can see right here. It looks like it occupies most of her canal. We know that her spinal cord is probably going to be over here pushed to the side. So this is a tumor. This is most likely a tumor of the covering called a meningioma. So we did a surgical resection. So here we've come in through the back of her neck. This is the tumor, which is resting inside the spinal canal and compressing the spinal cord. We're able to remove that tumor, decompress the spinal cord, and allow her to get some of her coordination back and her quality of life back. So that's all I have tonight about cervical spine disorders. There's so many more conditions we could talk about. Um, I just want to emphasize that at Rothman Orthopedics, we have a multidisciplinary team care approach to spinal conditions. So we have a lot of different physicians and physician assistants that provide care for patients with spinal disorders, from spinal physician assistants that are dedicated to spinal pathology. So they work very closely with the surgeons and the non-operative doctors. They are top notch. They know their spinal medicine as well as most other doctors. We have sports medicine doctors that deal with a number of various sports medicine injuries, and some of which are spinal injuries. Spinal physiatrists, which are non-operative spine specialists that help manage treatments, workup, and occasionally can do procedures to help patients deal with pain. One of the more common procedures might be an epidural injection. Those can be done in the cervical spine to relieve nerve pain or radiculopathy. Spine surgeons, we currently have 2 spine surgeons in Rothman Orthopedics, Florida. We'll probably be hiring our 3rd spine surgeon this next year. And then we've got great physical therapy teams that are very accustomed to treating patients with spinal disorders at most of our Rothman Orthopedics locations. So I'd like to thank you all for your attention, and I'd be happy to answer any questions you might have if you want to put those in the question and answer forum. You there, Melba?
I'm here, doctor.
All righty.
I don't see any questions in here, but let's give him a few minutes.
Sounds good. Well, either I put everyone to sleep or I don't think there's any questions.
I don't think so. It was a great presentation, doctor. I appreciate it. I'm sure I'm speaking on behalf of everyone who attended. And if there's any follow-up questions, or if you'd like to make an appointment, I will reach out to each and every one of you. You will receive a copy of the webinar, and we appreciate your attendance.
Thanks again for everyone's attention. Thank you, Melba, for your organization.
You're welcome, doctor. Thank you for presenting.
Well, have a good night.